That was kind of, a little bit interesting. I loved physics a lot, and I wanted to be a nuclear physicist in during my uh, early student life. But then somehow destiny made me a doctor, and now I'm loving it. So that was kind of a decision which I took while I was preparing my board curriculum after standard 10. And that time I decided that I have to be a doctor rather than a nuclear physicist. And so when I prepared for my joint entrance examination, I chose only for medical examination. So I was quite sure that I have to be a doctor, nothing else. So that was while I was doing my internship after passing MBBS. So back 10, 15 years, that time, actually that time in our generation, we are not so much focused that we have to do PG in next 1 year or 2 year. So we are from a generation where learning and clinical learning, all these things are more important than cracking the PG entrance examination. So somehow during one of my ward duty, I came through a cancer patient. It was a brain tumor, kind of very aggressive brain tumor. And that one scene, that one scenario in the ward gave me a tickling in my mind that, well, this can be a field where people are actually being neglected. If you consider the situation 15 or 16 years back, that time treatment for cancer was really very limited. The care for cancer patients were not much. So that motivated me to some extent that yes, these people require much more attention and care than anyone else. And while I was preparing for my PG entrance exam, then that kind of translated into a love for radiation oncology, because I found that radiation oncology is very interesting, where I can utilize the concepts of physics, and it's kind of technology dependent subject where you can actually expect a lot of things happening in next few years. So that motivated me a lot to choose radiation oncology over anything else. So Chirag, radiology and radiation oncology, once upon a time, it was a common subject in India. They got separated somewhere in 1979 or 1980, where when this subject was divided into two different subjects, one a diagnostic aspect and one therapeutic aspect. So when I say radiation oncology or radiology, many times we are actually using the same source of radiation. The difference is in its energy, or the way the energy is being produced and utilized. Say, for example, radiologists or the diagnostic radiation, they deal with more like CT scan, MRI, X-ray, ultrasound. Now, if you know X-ray, CT scan, they use the same X-ray which we use in our linear accelerators. So one of the very sophisticated radiation machine to treat cancer. The difference is while the radiologists use X-ray, the energy of X-ray is really very less compared to the X-ray we use through our linear accelerators, and the difference can be a million times actually. So you can assume the energy of X-ray coming from a linear accelerator is million times higher than X-ray coming from a diagnostic X-ray machine or a CT scanner. And there are definitely a lot of other technical differences between the machines. The way that radiation is modulated, or the field, or the area which I need to treat with radiation is actually shaped, given the shape. There are a lot of differences where we use a lot of softwares, technologies, but in reality or in essence, the same X-ray are being used or is being used in diagnostics versus or in therapeutic radiation oncology. The difference being the energy. Yes, so radiology is a subject which is concerned with diagnosis of some disease. That can be anything. That can be a cancer. That can be something else other than cancer. Now, radiation oncologists are almost always dealing with radiation for treatment of cancer. a field of medicine where we use uh, radiation or high energy radiation to treat different malignant conditions, means different tumors which are harmless and different tumors which are harmful or malignant. Other than that, that radiation is also used to treat some non-cancerous conditions. Okay, so it's not that radiation is always treating cancer. It can treat few conditions or medical disorders which are not cancer. And if I tell you what we actually do, so you can see that is how uh, our workplace looks like. It's full of computers. It's mostly an isolated place in the hospital where people are engaged mostly with machines, computers, softwares, and yes, a lot of patients. So, what we do in our daily life, definitely we see a lot of patients. So, we talk to them, we get to know their problems, their disease profile, or the way the cancer is presenting, or the cancer has spread in their body. So we do all kinds of investigations. We advise them many investigations, and then finally, after getting all the reports, so say for example, biopsy report, CT scan, MRI, or other scans, we finally reach to a conclusion that okay, this patient is having such cancer with such stage. Say for example, lung cancer stage 1, 2, 3, or 4. Now, that's one part of our job, that we see patients in our OPDs or clinics. That's like any other OPD in hospital. Say, for example, the people from internal medicine, they are seeing patients in OPD. So we also see patients in our OPD. There is not much difference. Now, if we come to our inpatient services, where we admit patients in our wards, so what exactly do we do? So most of the time, we admit patients in our wards to manage the side effects or toxicities of radiation. So radiation is something just like any other treatment. If you are treating some patient with radiation, it will give some kind of toxicity or some side effects. If the side effect is very high or much more, where the patient is having a lot of difficulties or a lot of problems, then we need to admit them in our ward. We treat them with a lot of medicines, sometimes depending on their condition, saline or IV fluids. Then another entity is there which we call radiation emergencies. Means there are certain things which needs radiation on emergency basis. Okay, so there are many situations when a patient with cancer require radiation on emergency basis. So those patients also get admitted, and we plan them for radiation. We treat them with radiation to overcome their acute or emergency problems. We also do in-house consultation. That means, say for example, some patient was admitted with some non-specific complaint, for example, under some general surgeon. And on evaluation, the surgeon found, or the internal medicine expert found, that the person is having some tumor in some part of body, say for example, a liver cancer or a brain tumor. So definitely at that point of time, they call us to discuss about the next course of action, how to investigate, how to decide their treatment protocol, and how to treat them. So that is part of our in-house consultation. Now, one important thing in India is administering chemotherapy. So that is something which we practice in many hospitals across India. So chemotherapy is something which are very toxic drugs most of the time. They're most of the time administered through IV fluids or intravenous fluids to treat cancer. So many institutes in India where this radiation oncology curriculum is running, as part of their daily job, they practice chemotherapy, or they need to administer chemotherapy. So we also need to learn about chemotherapy, their basics, the drugs, about their pharmacology, their side effects, the way we need to administer them, the way we need to treat side effects of those medicines, their indications, their contraindications, the dose, and everything, and how to administer them. If there is any difficulty arising out of that chemotherapy, how to manage them. That is also part of our job. Okay, and as I said, chemotherapy toxicity management is also part of our job. That depends on the institute where the candidate is working or where the radiation oncologist is working. It's not that all institutes or all radiation oncologists are practicing chemotherapy, but yes, in India, most of the radiation oncologists at this moment are practicing chemotherapy other than doing radiation for their patients. There is an idea that if I choose radiation oncology, I can escape night duties, but in reality, that is not. Okay, there are a lot of emergency situations where we need to be there at the bedside, and sometimes we need maybe the entire night we need to spend at hospital. So we do have night calls as part of our residency program, and even when we work as consultant or faculty, we do need to be there on call duties. So during residency, almost all hospitals or all institutions which are running radiation oncology program, they always give a schedule for on-call duty to their residents. So we do have OPD duties, we do have inpatient duties, and we do have emergency duties. It's very difficult, Chirag, because it's almost 12 years I am into this oncology field. I really do not remember how many patients I have seen and how many of them are really very difficult or very critical uh, to get cured. But yes, there are definitely some patients which are memorable, and I really do remember many of them. I can just share one or two. Like there was a very young and there was one young lawyer. I don't want to name her, working in a very reputed position. So she presented to us with one of the most aggressive cancers of nose and the sinuses. So you know sinuses. That's a lot of patients. A lot of people have sinusitis. Is the air-filled places around our nose. That was one of the very bad type of cancer which one can actually imagine. And when the patient came to us in her early 30s, it was almost just one, you can say in layman's terminology, one stage ahead the last stage. It was almost stage 4. And we treated her very aggressively with chemotherapy and radiation. The patient did have a lot of problems during this entire course of radiation chemotherapy, but she was courageous enough to tolerate the treatment. And almost after 4 years down the line, she is doing absolutely fine without having any disease. And that's definitely kind of something which we always remember. I remember another young guy who was having a very advanced cancer of food pipe or esophagus, you can say. So it was very difficult to even convince him for treatment. So the young guy was not actually willing for any kind of treatment. So the first hurdle for us was to convince him. After a lot of counseling, uh, we we were able to make him realize that yes, this can be treated. And really, we don't know about the chance of cure while we start the treatment, but yes, we do treat with the hope that it will be cured. And yes, after a lot of efforts, we were able to complete the radiation chemotherapy. After that, he underwent a big surgical resection, and then down almost about 1 year from his treatment, he is doing absolutely fine. He is doing great. He's eating normally. It really gives a very good sense, while such patients come to us. And I can remember another one patient. He was another young guy with lung cancer. where everyone from my hospital said that okay, this person is just having a few months in his life, just give some radiation which can just reduce his pain. So that patient I took as a challenge, and I treated him with kind of weird way of radiation, you can say. But after almost 2 years, he is doing absolutely fine. It's not only about oncology, our entire medical profession requires a very good uh, counseling skill that is absolutely required for any kind of treatment. And if you are aware that the moment a patient is coming to me, I need to have a good conversation with him or her, discussing all the details about the disease they are having, the way we can treat them, so the options of treatments, the expected benefits versus side effects, the cost. So all these things we need to discuss in detail. And definitely, in our country, cancer is considered one of the bad disease one can have. So by the time patients come to us, they are almost like in half dead situation. So the family members are like in a crying mode. Doctor, don't tell anything to my patient. He will just die the moment he is coming to know about this. So first of all, counseling starts from their family members. So first of all, I need to counsel the family members that this is not the thing. Actually, if you are getting a proper treatment in a proper place in proper time, your patient might get cured. So that once that hurdle is overcome, then comes counseling of the patient. So initial 2 3 months after knowing that their disease, uh, patients start accepting that fact. So that acceptance is very much required, and it requires a lot of effort from our side also to feel them comfortable even when they are having a cancer. That yes, you are having a cancer, but most of the time it can be cured. So that sort of counseling is definitely required, and giving the confidence to patient is also very important. Many times, patient does not come to our clinic or our OPD room. The family members enter and with a weird request that doctor, please don't tell anything to my patient. I sometimes, so the counseling starts from that point of time, that if it's not done that your patient is having cancer, he will undergo treatment which is sometimes 6 months or 1 year long, or even more than that, and we cannot hide this fact. So it's always better that let them know, let them fight their own fight. So give them the courage to fight. That is what is much more important. So if you ask for me, it's very difficult. I hardly get any time to give to my family. But yes, it all depends on an individual. So it requires a lot of commitment, and the hospital where I work is, it's like one of the most crowded hospital of India, and that requires spending a lot of time in hospital in radiation area for proper planning, for verification of radiation planning, for verification of treatment, to evaluate their toxicities, and then involving in research work. It really takes a lot of toll on our personal life. It's not easy. To be very frank, Chirag, when you said about when you contacted me about doing a career counseling on radiation oncology, the first thing which came to my mind is job opportunity. And if you see, first line in this slide is not great in India as of now. So
All
why
right.
is it not great? It's a technology dependent subject, and it's one of the most revenue generating subject in Western worlds, in developing countries like US or UK or Canada, in Singapore, or countries like Singapore, or many countries in Middle East. But unfortunately not in India. So the reason are manifolds actually. It's very difficult to pinpoint particularly one reason. So one of the biggest problem is lack of infrastructure and lack of awareness on the part of the people what radiation oncology and radiation oncologists are supposed to do. Okay, so it's like we produce a lot of radiation oncologists in particular year. I'll show you that the number we are producing every year. But the facility or the setup to absorb them, to give them proper job with a decent salary is not very good as of now. But one should not be demotivated, because if someone is good, definitely he is going to do good. So if I want to divide the job opportunities, so you can divide it into government sector and private sector. So the moment one is having the degree, MD or DNB, they're uh, eligible to apply for senior residency in big institutes like AIMS, Tata Memorial Hospital, PGIMER Chandigarh, or like such central institutes where a lot of MD students are absorbed as senior resident. Now, they can also apply for some research work in some selective institutes. Not all institutes are having research facility, but yes, big institutes like Tata Memorial Hospital, All India Institute, so they are also having some opening as research fellows. And if someone is lucky enough, then yes, he can also get a permanent faculty position. Salary in government sector is not yet great compared to private sector, where definitely earning is much more. Senior residency, yes, it's available in private sector as well. And uh, right after completing the MD or senior residency, people are usually absorbed as consultants, but without having patients right. That means they cannot register patients under their own care, but yes, they can work as an associate to some senior consultant, and they're expected to learn their job properly. And once they are confident and they're supposed to be good in their field, they are usually offered a full-time permanent consultant post. Other than that, one unusual job opportunity is pharmaceutical company. So I know a few guys from my own field who are now working as into big pharmaceutical companies for drug development into oncology. So the cancer drugs, the chemotherapeutic drugs. So they are into research related to this field. So definitely, that's another career opportunity one can think of. So I this it's like that when you are asking about the earning, it depends actually. Government sector definitely not a very well-paying sector, but it gives you the satisfaction of treating the poor people who are needy and who cannot afford care in some corporate hospital. So you can treat them in a good way, accepting the fact that your earning will be less. And private sector usually gives a decent salary, but then the problem is it's always very demanding. The pressure is definitely very high in private sector, and all these things are definitely less compared to government sector. So these are some shortcomings vis-a-vis some advantages of both the sectors. So let me show you the curriculum we have in our country. So as of now, related to radiation oncology, we have MD in radiation oncology or radiotherapy, both are similar. DNB in radiation oncology, and in very few hospitals, diploma in radiation oncology. Although the diploma curriculum is almost abolished all over the country, but yes, few hospitals are still running those diploma curriculum. Now, the, the duration of MD and DNB are they're 3 years. The diploma curriculum is 2 years. Someone choosing to do an MD or DNB after finishing the diploma course can finish this in 2 years after completing their diploma. And for very few who love to fly, who are willing to take the risk to go abroad, then these are the good options as of now. US and Canada, where they need to clear MLE first, USMLE, or some equivalent exam for Canada. Then they get to work as initially as fellow, and if they're lucky, then they're absorbed as into their residency program. After finishing their residency, they're offered the American Board Radiation Oncology certification or ABR certification or similar certification for Canada, and then they can practice as independent consultant. Needless to say that US and Canada at this moment, these two countries are one of the most or highest paid countries for radiation oncologists. So in US, radiation oncology as of now is chosen by the top rankers, if you can say like that. Now, If someone is willing to move to European countries, then they have to clear FRCR and PLAB. So someone can go to the website of Royal College of Radiologists, and then they can start the option for radiation oncology. So Royal College of Radiology have the fellowship. The name is similar for both radiologists and radiation oncologists. So it is FRCR for both of them. So there are diagnostic radiology and therapeutic radiation. So someone needs to be very careful. And then the third option is going to Australia, New Zealand, where they need to clear the examination to get the fellowship under Royal Australian and New Zealand College of Radiology. So if you see, all these are actually radiology, but one is diagnostic and one is therapeutic. So basically, it's the same radiology as I said in the beginning. There's few decades back, it was a common subject. So that is why you can see ABR, American Board of Radiologists, FRCR, France. So all these are basically radiology related colleges of these countries. Now, someone having qualification from any of these countries are actually having a good job opportunity in Middle East countries, which is like an open field. There are a lot of countries in Middle East which have good opportunities. They pay very well, good lifestyle, not too hectic work like we are having right now. So someone can think about that as well. So as I was saying you, Chirag, that the supply and demand. So as of now, we are producing almost 337 qualified people every year in field of radiation oncology. If you see, this is seat matrix I got from the latest one from MCI website, from NatBoard website. The total number of MD MD seats at 308, DNB 17, and diploma 12. That makes it roughly 340. But if you ask me, is there a good job opportunity for all these 340 people? No, that is why we are lacking. Maybe in coming few years, as because number of oncology institutes are rising with very good setup, people are bringing in a lot of costly machines, sophisticated machines. So they also need good people to work. Maybe the scenario can change in coming 5 or 10 years. To be very honest, during MBBS, as per our curriculum, we really do not need to do any research to pass the exam. But if someone is interested, then sky is the limit for him. There are a lot of research protocols going on under ICMR, where they can participate, they can write project, they can work in collaboration with their senior faculties. So that's one research opportunity, but I really do not know whether that research opportunity will help them in future or not. In reality, it may not, but it can give them personal satisfaction. Now, coming to during their curriculum or during their doing their MD or DNB, they have to do one research work as part of the curriculum. So they have to do the thesis or a research on some aspect of oncology that may be related to radiation, that may be related to combination of radiation and chemotherapy, and so on. So that's mandatory for getting the necessary qualification. Other than that, usually the students who are working in a well academic environment, they are mostly engaged into some kind of research work that starts from writing case summaries, publishing a series of data, or doing some really innovative work, and they can publish it in some good journal. That always gives them an edge over others during getting the job or getting some fellowship or getting senior residency, all these things. So if someone is willing and someone can do all these things, he will definitely get some preference over people who are not doing this. And once they're into their real life practice, they can always continue the research work, but again, the question comes whether research work is mandatory for private practice or working in a private hospital versus in a government hospital. That depends actually on the mindset of the person. It's not mandatory. Maybe it's required for getting promotion in government jobs, but for private job, definitely it's not mandatory. But someone can do research to remain on cutting edge in the subject. it's always most welcome. Enormous scope of research is there related to
Exactly.
newer molecules, related to radiation technologies. There are a lot of research scope. And
Great,
I
sir.
just wanted to show how do our machines look like. Someone might get might get more interested after looking these machines. So see, this is something very, we call it very basic linear accelerator nowadays. But even the basic linear accelerator costs something around 20 to 25 crores. So this is backbone of any radiation oncology department, a good linear accelerator. Then if you see, this is one of, now I'm going to towards more sophisticated radiation machines. This is known as gamma knife, where uh, the very small tumors are treated in just one day, one session. So it's gamma knife, we call it radio surgery. So it's not any surgery happening with scalpel or blade, but in effect, the radiation is so precise that the tumor is cured, just like the surgeon cuts the tumor with knife, the tumor is cured here with radiation. So it's a machine like that. Then it's another very sophisticated machine known as cyber knife. Then it's a tomotherapy. It's a advanced linear accelerator where one MRI machine is incorporated with the same machine for precise treatment. And the latest machine, proton beam therapy, which is kind of happening thing all over the world right now. So these are, you can see the look of these machines are what I say, so sophisticated. Someone might get interested just after looking this machine, that okay, I need to do this subject. It's a very sophisticated, very precise thing. See, technology is something which is always better picked up by young generation. It might happen that after 20 years I am unable to pick up some new thing, but my juniors will be able to pick up that very fast. And young generation should come forward for all these technology dependent subjects. You cannot really expect great things to happen with old people. There are definitely exceptions, but that's not the rule. The rule is young people do the magic. So they have to come to this field. So, if someone is willing to become a radiation oncologist, the basic requirement during MBBS is to read all subjects with equal importance, because they have to crack the PG entrance. So, while they face the questions during PG entrance, there is hardly any differentiation, or there is no segregation between a candidate who is aspiring to be a radiation oncologist versus someone who is aspiring to be a radiologist. The questions are common, and it's spread all over the 22 subjects which are into MBBS curriculum. So they need to read all of them equally so that they can answer all the questions in their entrance exam. In our country, other than one or two institutions, all other institutions have chemotherapy in practice with the MD Radiation Oncology curriculum. During DNB, so there is big difference between MD and DNB. So most of the time, this DNB curriculum is happening in private hospitals. So practicing chemotherapy in private hospital by radiation oncologists is not a common thing. So they are not getting that much opportunity. But yes, in government hospitals, all hospitals in India, barring few, are practicing chemotherapy as part of their MD curriculum. To highlight another thing, because I expected this question, so I think it's almost at the end of my presentation. See, it's not an alternative to internal medicine, and if there are people who are confused between internal medicine and radiation oncology. So I have seen people who were very interested or keen in doing internal medicine, but somehow their rank was not that much good to get internal medicine in some good institution. So they chose radiation oncology as an alternative of internal medicine. That's not done. Radiation oncology is not at all internal medicine. It's completely different subject. Clinics is part of the medicine, part of our curriculum, but that's not at all internal medicine. So if someone is confused whether can I take radiation oncology because I love internal medicine, the answer from my end would be it may not be a right choice. If you are loving internal medicine, then rather you wait for another 1 year or for next exam to get internal medicine. So radiation oncology is a subject which should be chosen by freaks. That means they're already motivated about the subject and they should choose this subject, not the one who were willing for doing internal medicine. Now, at this moment, as career opportunity, you have the option of applying for DM curriculum. So once you are done with your MD in radiation oncology, you are diehard internal medicine fan and you want to remain some in some subjects, or you want to do medical oncology, you want to practice dedicated chemotherapy, then you might choose a DM pathway. So you have to write another entrance exam. Similarly, like this NEET and PG entrance, there is a need for specialization after MD. So you have to crack and you have to get DM medical oncology in some institute where DM medical oncology curriculum is there, or DNB medical oncology curriculum is there, and then you can practice dedicated chemotherapy. That you can do. That is another career option. So MBBS, MD in radiation oncology, followed by DM in medical oncology or DNB in medical oncology. And let me assure you, someone from radiation oncology background becoming a medical oncologist will definitely do great in his life. I don't think there is any medical specialty as of now which can save 100% people. So it's so death is everywhere. It's not only in oncology. All patients die sometimes. All people who have come to this world, they definitely have to leave some point of time. So that acceptance should be there in any field actually. Patients die from cardiac arrest, patients die from stroke, patients die from diabetes, patients die from trauma, so and so on. So rather I would say that cancer is something which can be cured. If you consider diabetes or if you consider hypertension, they are never cured. Or at least if people are aware they are coming when the tumor is in very early stage, they can be cured. So that's definitely something which gives me a lot of satisfaction at the end of the day, that yes, I can cure someone. The moment someone is becoming a doctor, it has to be accepted that not all patients can be saved. So the motivation should be, even if I save one person, that is my achievement. Should be there to make a difference in at least one person's life. I cannot make difference in thousands' life, but yes, I can make a difference in life of one person or two persons. So death is inevitable, so that the patient is happy at the end. So the patient's relatives are they can get solace that yes, my patient got a proper treatment, a caring treatment. That is definitely more important. Oh, not at all. Not at all. So, my fascination for radiation oncology was actually even bigger when I was preparing for my PG entrance. So, that time actually, those questions started coming in, like IGRT, IMRT, and the small amount of information which I read that time, they were quite fascinating. That, oh, wow, if radiation can cure without even doing an operation, then nothing like it. So, hazards are part of our life as in medical profession. So everyone is working with some risk of having something. Like the surgeons are working with the risk of getting HIV or hepatitis B from needle prick. The intern who is working in ward, they are working with the risk of getting some needle prick injury. So that's part of our life. So radiation didn't make any additional difference to that list of professional risks to my life. I was quite sure about that. The today's era, the way we plan or the way radiation oncology is happening, physicians are not the actual one who are delivering the radiation. So our job is mostly limited into clinical work in clinics, working up the patient, evaluating them, then doing the radiation plan, sitting in front of the computer, dealing with software, and verifying them during their treatment, which actually gives a very negligible dose of radiation. So that amount of radiation one can actually have during a flight journey from Delhi to New York. So you can get equal amount of dose of radiation from a flight journey. So it's not that much big. So actually I made one slide, that I am so afraid about radiation. So it's not going to give you radiation as a professional. The risk is very less. Nowadays everything is computer controlled. Sources are mostly electronic, where the radiation source is actually virtual. So the moment you are switching on the machine, radiation is there, which is hugely shielded so that the workers do not get high amount of radiation. So you are actually safe from all sides. Until and unless you are doing some gross error in your day-to-day life working, you are not going to get high dose of radiation. So it's within tolerance. It's a very a tricky question to answer. Actually, many times I came to know about few of these celebrities. Many of them are actually getting treatment by some Indian doctors while they are in US, but they are not getting treatment in India. The reason what I assume, this is, I don't have any evidence to support. Our media is very horrible. They will literally barge into hospitals, even inside ICU. If you have come across a recent video, that they do not even bother, they do not even mind to enter ICU, so they can enter anyone's room, and that will make the celebrity's life miserable. Celebrities cannot reveal each and everything in open, so they have to have some kind of hide and seek business. Going abroad gives them that shield. That is what I believe. But I know
Yeah,
many
I mean,
VIP or VVIPs actually who got their cancer treatment done in India only. Nobody know that. So it's not that all VIPs go outside. It's personal choice. That's actually very horrible. I just recently saw one video where one journalist entered the ICU without proper protection, without following any ICU protocol. So media, kind of, they're very much irresponsible, and you never know the way they will represent the facts, what is happening with a celebrity's life, which can actually ruin their career as well. So I think it's their professional um kind of professional secrecy they want to maintain. So the physics which we need is a kind of very basics of nuclear physics and some basic understanding. You do not need to be Einstein or something like that to be a radiation oncologist. You have to be good in dealing with computers and gadgets. That's all. So, first of all, I need to clarify that radiology is something completely different from radiation oncology. Nevertheless, I can answer your question. Here I have some basic idea about radiology also. So, I think it's someone who have a very good observation. So they would definitely do good in their life as a career of as a in their being a radiologist. So they would definitely do good if their observation power is very good. But yes, as of now, the radiologists are not. They do not come in direct contact with the patients till the time they're doing non-interventional radiology. That means if they are doing only CT scan, MRI, ultrasound, so the relationship ends there. You are getting your ultrasound done, and you say bye bye, and it's done. But the moment you are engaging yourself into some interventional radiology practices, then yes, you are actually into patient management. So you are dealing with patient will come to you, they will be treated by you, and you can have a lifelong relationship with that. Now, being a radiation oncologist, yes, you do have direct interaction with patients and you are treating them. So it's not diagnostic branch, it's therapeutic subject. So it's just like a surgeon is doing an operation, an internal medicine expert is giving you someone medicine. You are treating patients with radiation and medicines or chemotherapy. So you do have very good bonding and relationship with your patients if you are willing to have that. So I have a lot of good people in my contacts who consider me as their friends, family members, and all these things. So it's all depend. It all depends on the way you are dealing with your patients. So if you can treat them very in a very good manner, in a proper way, they will definitely like you and they will definitely try to be in touch with you. So you will never feel that you are not a doctor. That's completely different scenario. But radiology, yes, there is some speculation, but I have seen people who are not willing to have those hassles of night duties, daily stress after returning home. So usually they choose radiology. That gives a much more peaceful life. Once you are back from your workplace, you are free. But yes, radiation oncology is not like that. You have to be in touch with your ward, your hospital, whenever required. So if you start as a senior resident or if you start as a junior resident in government institute, you are going to get salary which is at par with the salary structure of the state government. If you're working, so sometimes that salary is as low as 30,000 or 35,000. If you are fortunate enough to get your residency program in some central institute like AIMS, PGI, or something like that, then you are going to get salary somewhere in around 90,000 plus minus. Now, once you are done with your junior residency program and you are entering as senior resident, you can expect a hike of something around 10% to 15% to that this figure. Now, when you are joining after senior residency, again the salary structure in government sector and private sector is different. So to begin with, mostly what I have seen in Delhi and surrounding region, the salary of a beginner is somewhere around 80,000 plus minus 80, 90, 1.1 or 1.2 to begin with. And depending on your performance, you can be upgraded to associate, consultant, and so on, and your salary will increase. In government sector, again, it all depends on the pay scale of the respective institute. The central institutes are having little bit better salary structure compared to state-run hospitals. Usually, when you are starting your permanent job in a state-run hospital, you can expect your salary somewhere around 50 to 60,000 to begin with. The same thing when you are doing in some central institute, you can expect somewhere around 1.2 or 1.3 to begin with. So initially I thought, Chirag, that the students would be aspiring for their MD or MS entrance. So actually I made some specific things for them, what to look for when they're choosing radiation oncology as their subject, and what to, so I can easily skip this one. And these are some good institutions in India where you can expect an excellent radiation oncology facility. So just to name few, like All India Institute of Medical Sciences, Delhi, Tata Memorial Hospital, Mumbai, PGI Chandigarh, JIPMER Pondicherry, RML IMS at Lucknow, which is a very good center coming up in a great way nowadays, SGPGIMS Lucknow. Among some few good state-run hospitals, I have definitely mentioned my own Medical College Hospital, Kolkata, then RG Medical College, Kolkata, then NRS Medical College, Kolkata. So they're all having very good setup at this moment. To name few among private hospitals, definitely I would mention Chennai Apollo, because they are the only one as of now in our country where you are having proton beam therapy facility. And Tata Medical Center in Kolkata is another private hospital which I really need to admire because of their excellent setup. So even in future, if you are considering radiation oncology as your career opportunity, then do give importance to these institutions. And at the end, what I would suggest that it's very important to make sure what you want in your life. So you think, where do you want to see yourself after 5 years, 10 years, 20 years down the line? So that is very important to understand and choose wisely, because this is something which is a single time phenomenon. You can choose only once in your life if you are not doing another MD or MS from some other university. So if you don't want to lose 3 years or 2 years or 1 year from your life, choose very wisely before selecting radiation oncology. It's not a cup of tea for everyone. It's very fascinating subject. It can do wonder, but in uh, with a proper setup from some proper person who are having the mindset to accept this fact that radiation oncology is something in between medicine and technology. So if you're accepting these facts, then you all are welcome and all the best for a very bright future as a radiation oncologist. So that is what I can say.